Good morning, doctors. Welcome again. Today we are going to discuss about hypertrophic cardiomyopathies and hypertrophic obstructive cardiomyopathies. Okay. Disease process affecting the myocardium, the contractile muscle cells of the heart. Cardiomyopathy means the disease of myocardium, pathology of myocardium layer of heart. Impairs heart ability to fill properly or pump properly. Filling means diastolic failure or pumping means systolic failure, which leads to retention of blood in cardiopulmonary circuit. Hence CHF. Congestive heart failure symptoms are possible in all cardiomyopathies. The best diagnosis or investigation of choice in any kind of cardiomyopathy is 2D echo or echocardiography. Keep an eye out for concomitant atrial fibrillation. If atrial fibrillation happens, then go for treatment with digoxin and warfarin. Okay, but the drug of choice in atrial fibrillation is beta blockers. Okay. Now, let's discuss hypertrophic cardiomyopathy. Non-obstructed hypertrophic cardiomyopathy versus obstructed type of cardiomyopathy. Causative or idiopathic hypertrophy of myocytes result in thickened walls and reduced luminal volume. Due to hypertrophy, the walls are thickened and reduce luminal volume. Somewhat analogs to diastolic heart failure, means heart is not able to relax, but contract well, so not enough blood is filling. That's why it's hypertrophic cardiomyopathy. Most common cause of hypertrophic cardiomyopathy is hypertension. Hypertension is the most common cause for left ventricular hypertrophy, remember. And some case causes are idiopathic for hypertrophic cardiomyopathy. Most common presenting symptom is syncope. Other includes angina, palpitation, dizziness, and CHF symptoms are less pronounced, more common in advanced SCA. Syncope occurs due to reduced blood supply towards brain, and angina occurs due to reduced blood supply through coronary arteries. Okay. Now, hypertrophic obstructive cardiomyopathy, similar to hypertrophic cardiomyopathy, non-obstructive type, but in this case of HOCM, there is blockage of outflow tract blockage. Part of the hypertrophied interventricular septum is blocking the path of blood through the aortic valve. Remember, hypertrophied interventricular septum blocking the path of blood through aortic valve. This will result in murmur similar to heart in aortic stenosis. In aortic stenosis, we see systolic crescendo, discrescendo at the right upper sternal border. In aortic stenosis, we see murmur on crescendo, decrescendo. Okay. Also, most commonly presents as syncope, but may also shows up chest pain on exertion or sudden death. Sudden death most common in hypertrophic obstructive cardiomyopathy, but in hypertrophic cardiomyopathy it's less common. Worsen with anything that reduces the left ventricular volume. This hypertrophic obstructive cardiomyopathy works when something reduces the left ventricular volume. For example, let's discuss anything that decreases left ventricular volume will worsen hypertrophic obstructive cardiomyopathy and place the patient at risk for complications. Preload reduction by hypovolemia, tachycardia, decreased ventricular filling time, Valsalva, and arrhythmias. But afterload reduction is by positive inotropes like digoxin, dobutamine, etc. And beta agonists like salbutamol, etc. they reduce afterload reduction. Nitrates and AC inhibitors reduce afterload reduction. What is preload? Preload is diastole, means filling of blood reduced. That is due to hypovolemia, tachycardia. Tachycardia, why? Because ventricles are working very, very fast. That's why decreased ventricular filling time. Filling time is reduced. That's why. And arrhythmias causes so. And afterload is contraction of blood, contraction of heart and ability of heart to pump out. So that is decreased by beta agonist, nitrates, ACE inhibitor, and positive inotropes. Okay. Now, hypertrophic cardiomyopathy and HOCM, the diagnostic of choice is echocardiography, which shows the left ventricular wall is thickening than right ventricular wall. How to treat both of them? By beta blocker, metoprolol are the mainstay treatment, increasing diastolic filling of ventricles. It increases after load. Calcium channel blockers, verapamil, can be used in place of addition to beta blockers. Okay. Other drugs used include disopyramide, negative inotrope, or amiodarone antiarrhythmic. Stay hydrated. Avoid strenuous activity. Avoid any drug that may reduce left ventricular volume. For example, ACE inhibitors, nitrates, positive inotropes, beta agonist. It's not a beta blocker, here is beta agonist. Okay, avoid. Surgery reserved for refractory cases, catheter septal ablation, myocardectomy. Need prophylactic antibiotics. In this condition, we need prophylactic antibiotics. So guys, I already finished with hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy. Even I discuss in my live classes also, you can watch on YouTube, and this is written notes I will provide you. Thank you, good day, goodbye. That's all for today. If you have any queries, any question, you can ask me, and if you're new on my channel, please subscribe it. Thank you once again. Good day, goodbye.